All right, let's get back. So we ended with cervical cancer. What we're going to do is finish a little bit of the gyne, and then we're going to go into the OB stuff that we need to sort of cover. So the last little bit of the gyne part has to do with abnormal vaginal bleeding. And I tell you that I don't think this is anything right for a question on an exam. The key about vaginal bleeding is your first decision point is pregnant and non-pregnant. And it's an entirely different ball game. If you're dealing with a pregnant person who's bleeding, the non-pregnant person who's bleeding, in fact, anyone bleeding from down there, you need to make sure you figure out where they're bleeding from. So make sure, first of all, it's from the uterus. And then it's pregnant or non-pregnant. And our job, honestly, is not what the source is. That's what our gynecologist friends are for. But our job usually is to make sure that they're hemodynamically stable, if they're anemic, to sort of address that appropriately, and then get them referred as far as why they're having their non-pregnant vaginal bleeding. Again, so that's our sort of stability thing. Let's switch to OB. So when it comes to obstetrics, most of us that work in emergency departments, if you work in a big city or in a big hospital, we don't see a lot of the second and third trimester issues because often those patients will go up to L&D. But the reality is if you work in a small hospital or a hospital where you are you will be taking care of these folks. And on an exam, they don't care where you work. They want you to know about all this stuff. So let's get into this and talk about the obstetric things. We know normal pregnancy, those of you who've had babies or those of you who women who've had your own who realize that you're giving birth to a bowling ball with a little tiny body attached to it. But this wonderful creature that you get pregnant with is basically a parasite for 9 months, and then will cost you $300,000 to get out of the house as you grow this child in your home, that you will love this little creature more than life itself. I mean, having children is incredible, and what happens to your body is remarkable with pregnancy, absolutely incredible. A couple things to know about it from a medical standpoint as far as what we deal with. Basically, pregnancy tests these days, back in the old days, these were not so much, but these days, pregnancy tests are incredibly sensitive. In fact, they're sensitive in the blood down to a matter of 25 international units, which is almost when the egg and the sperm shake hands. It basically is like the moment of implantation virtually. And urine pregnancy tests are very, very sensitive. So if you have someone that is a vaginal bleeding patient or a person with abdominal pain, lower abdominal pain, you're worried about a pregnancy-related issue. If their pregnancy test is negative, it's negative. Our tests are good enough that it is virtually impossible to have a pregnancy-related complaint with a negative pregnancy test. So that's one thing. Usually it's 1 to 2 weeks of gestation, but honestly it's even a little bit before that. 7 days is for sure, and that's just really early in a pregnancy, so most symptoms don't occur until later on in the pregnancy. As you're pregnant, women will have symptoms they'll know. They get breast tenderness, they get nausea and vomiting can go with it. There's symptoms that just you're pregnant. And the other thing that happens is while this little parasite is growing in you, your body makes these incredible adaptations. Amazing adaptations. Besides the fact the uterus goes from about this big to this big and back, which is incredible, you also develop a whole lot of extra blood volume. And you do it more plasma than cells. So you are relatively anemic. You're not really anemic, you just have more plasma than cells as sort of, your coagulation factors kind of get a little bit screwed up, your cardiac output goes crazy, every woman knows, your lower esophageal sphincter gets loose and you end up with lots of GERD, lots of things change in your body. So a lot of them will affect things like trauma in pregnancy, which you heard about with Billy, we'll talk a smidge about, where things become a little more problematic because you've got extra volume to deal with and this relative anemia becomes a problem. The other sort of landmarks in pregnancy that help us in the emergency department, and especially if you have a pre-hospital setting where you're dealing with this on the radio, is the umbilicus. When the fundus hits the umbilicus, so you are pregnant enough that you can feel the top of the uterus at the umbilicus, that's a 20-week gestation. And the reason that that's important is it's near viability. And if there's any sort of wiggle room in this being even just a smidge above the umbilicus, you now have a baby that's potentially viable in there, a fetus that's potentially viable, which makes a difference on how you handle some of the issues that occur. It also helps us figure out sort of trimester issue. You can feel the uterus out of the pelvis. You're definitely more than 6 weeks and usually more than 12. So it gives you an idea of how pregnant someone might be. And then the last little bit of sort of background on pregnancy that's important for us in our practice is to know that not only is the pregnancy test as far as qualitative positive really early, so urine pregnancy test, the thumbs up, yes, you're pregnant, is positive really early. Your HCG in the first sort of 7 to 8 weeks of pregnancy doubles about every 2 days. So a good sort of rule of thumb is it should double every 2 days. And you need to know that fact because when they write questions, in real life for sure, but when they write questions on exams, they may give you something like, woman had a quantitative, knows her quantitative pregnancy test on Monday was 750. She now presents on Thursday. You're going to need to know that her if she's doubling normally, she should be well over 1,500 at the time that you see her. So that particular number is important to kind of have in your mind as far as dealing with particularly early trimester pregnancy issues when we deal with this. So just know that doubling is about every 2 days. Now, when pregnancies go wrong, when something happens with a pregnancy, the abortion group of things that can go wrong with pregnancies kind of fall into several categories. Threatened is where the baby's still in there, but there have been some symptoms saying this one may not hold, this one may not stay. And that's usually cramping or bleeding. On our exam, the os is closed. There's still something up inside. It hasn't all cleared itself out. There's still something up inside. Baby's still inside. It's less than 20 weeks in duration, or in gestation. And basically, the treatment for this is vaginal rest and normal activities. So they don't have to be at bed rest. The old school was bed rest only. This is basically nothing goes in there, but go about your business. Because the reality is, if it's going to miscarry, very little will change that, but you don't want to mess with the cervix. So nothing goes up inside, vaginal rest, and then your usual activities. An inevitable abortion is where they've had cramping and or bleeding, or maybe even some passage of tissue, and the os is open, and even anything that's still in there is not going to stay. So that's basically an inevitable. It's an open os, less than 20 weeks of gestation, usually treated with either watch and wait or a DNC, where they actually go in and just take what's left in there and just clean it out and start over again. Incomplete is basically some has passed, not all of it has passed, but the os has closed again. So they've had some bleeding, they may have passed some what they think is tissue or some clots, and when you see them, the os is still closed, but they haven't completely passed everything that's in there. And what's interesting about this category is that things have changed in what they throw in there. So we used to have a category called intrauterine fetal demise, where basically baby started to grow and then stopped growing and died, and then eventually need to pass. We also had blighted ovum, where it wasn't ever completely normally fertilized, things started to do something and then just didn't. Those two things now fall under the category of incomplete abortion. So it's bleeding, or there's something in there with no more heartbeat. There's something in there that started to grow and it's not even ever really even formed a fetus. Or something's passed and there's still something left. Those are all incomplete abortions. And those basically are treated usually with a DNC. So those usually get followed with DNC. So that's the categories of abortions. The thing that we worry the most about, and we should in the emergency department though, is ectopic pregnancy. So ectopic pregnancy, we talked about PID in the first half of this lecture and the fact that there's so much PID and it's led to all these complications. Right now, 1 in 50 pregnancies in the United States is an ectopic pregnancy. 1 in 50. It is remarkable the amount of scarring that has happened in the upper genital tract of North American females. It's incredible. So ectopic pregnancy is something that we all see. We absolutely see. And there's certain risk factors that increase your risk of ectopic pregnancy. I'll tell you the biggest one, honestly, is if somebody's had a tubal and they get pregnant, the odds are extraordinarily high that pregnancy is out there in the tube. It's out there in where it shouldn't be. So that's a really big risk factor. But the reality is, even with the risk factors we know about, having had PID, multiple sexual partners, et cetera, even with that, almost half of women who have an ectopic have no known risk factor, which again goes back to this PID thing that's been brewing along in a lot of the women for quite some time. So tubal ligation put up there. Now the characteristics, usually ectopic pregnancies don't become symptomatic until someone's been pregnant for 5 to 8 weeks or so. So this isn't something, again, that happens super early. This is something that happens 5 to 8 weeks in. And they can come in with anything from just some abdominal discomfort to a little bit of spotting to true, honest to God, ruptured, hypotensive, super sick. We know the range is enormous when they have this. Our job is to figure out, is today's problem an ectopic pregnancy? And the way to do that is you have to get a quantitative beta and an ultrasound, and preferably a vaginal ultrasound. And putting together the information of how high that beta is and what you see on that ultrasound, you'll be able to determine, is this an IUP, where it belongs? Is it definitely growing out somewhere where it shouldn't be? Or based on this quantitative beta I have, I should see something that I'm not seeing. And so you put those all together, and you're going to be able to figure out if it's an ectopic pregnancy or not. So the quantitative beta HCG ends up hugely important. If you see on ultrasound an intrauterine pregnancy, so there's a gestational sac, a yolk sac, a fetal pole, and better yet, a heartbeat, you have an IUP. Okay, there is something growing in the uterus, there is an IUP. Short of that, things get a little bit dicier. So if they give you, and I'll tell you right now, those of you who are a little gray around the temples, if you are not comfortable reading ultrasounds, basic ultrasounds, you have to be comfortable with it on the exam. These are now on the exam, these are out there, so do whatever studying you need to do to know this is a first trimester pregnancy. The gestational sac is the bigger sort of dark mark. The sort of white circle is the yolk sac. And to be frank, there's two little white lines at about 3:30 around that circle. That's probably the fetal pole. And it's in the uterus. This is basically an intrauterine pregnancy. It's one step short of the heartbeat, which is next, but this is diagnosable as an intrauterine pregnancy. Ectopics mean that it's actually implanted somewhere outside of that uterus. So it's out in the tubes, it's out, which is the most common place they implant. They implant out in the tubes, but they can even implant out on the mesentery. They're just growing somewhere they shouldn't be. The key number on the beta HCG to know is 1500. The reason 1500 is important is that at 1500 on an ultrasound, you should see something in the uterus. It doesn't have to be a perfect gestational sac and yolk sac, but something should be growing in that uterus at 1500. If it's completely empty, there's something growing where it shouldn't be. And we'll come back to sort of the dividers in a second. So the ectopic pregnancy, this is an ultrasound. The bottom thing on the right there basically is an ectopic pregnancy and an intrauterine pregnancy. And I want to mention this briefly. I honestly don't think they'll hit this for you on exam, but I want you to know something. Let me back this up. If they say on an exam, a woman who is an IVF patient comes to your emergency department complaining of vaginal bleeding, what they're going to want you to know is that in IVF patients, because they're having either embryos injected or they actually have ovarian stimulation, the odds of one in, one out at the same time skyrocket. It's called a heterotopic pregnancy. I see one in the uterus. I see one out, something that shouldn't be there outside of the uterus. That's called a heterotopic pregnancy. It used to be 1 in 30,000 pregnancies. Now it's down to 1 to 400 pregnancies. And most of the time we don't see it in the ER because our IVF colleagues are all over this. They're very, very careful. They know about this risk. But if you have somebody who de novo just comes into the ER, especially on an exam, if they give you the words IVF patient, and there's a pregnancy-related problem on this, please remember heterotopic pregnancy is increased risk in that group. Now, as far as diagnosing, let's get away from the heterotopic for a second, the 1 in, 1 out. Let's get to just a regular old, I'm pregnant with one thing somewhere. If you have an ultrasound that shows a gestational sac, a yolk sac, fetal pole in the uterus, you are finished, okay? Unless it's an IVF patient, the odds are extraordinarily high, that's a normal pregnancy. If, on the other hand, you have out there in the adnexa somewhere, you have what looks just like what should be in the uterus, but it's out, so you have the gestational sac, especially if there's a yolk sac in it, out there somewhere, that is a diagnosed ectopic pregnancy. If you have a beta over 1500, the discriminatory zone, and an ultrasound that shows nothing in the uterus, just an endometrial stripe and absolutely nothing, not a blip of anything, just nothing, that is also diagnostic of ectopic, because at that level you should see something growing in the uterus on a transvaginal ultrasound. That means, and the accuracy of that is 97%. It's extraordinarily high. Any other combo, I have a beta of 1,000 and I don't see anything anywhere. That's not high enough yet to be sure you could see something. If I have a beta of 500 and I don't see the low betas, you just may not see anything yet. Or the flip side, say I have somebody with a beta, you can rupture an ectopic pregnancy, lethal level rupture, even with a low beta. So if you now get an ultrasound that your beta is kind of low, but there's a lot of free fluid in there and the patient's really symptomatic, you now go on your clinical judgment. I can't prove it's an ectopic, beta's too low, but boy, she's unstable, her hemoglobin's dropped, it's rupturing out there, it's just not a high enough beta yet for me to see a pregnancy out there, but she's unstable. So ectopic pregnancy is kind of a nuanced problem, but if you put all the pieces together, your quantitative and your ultrasound, you'll nail whether the pregnancy is where it belongs or not, if the patient's stable or unstable. So you'll nail this. So here basically is what what the ectopic pregnancy would look like on an ultrasound. So they're giving you on that top left-hand picture, the right-hand blob of stuff is the uterus with basically schmutz in there. Okay, it's a thickened endometrium. It's kind of schmutz in there. But if you look now out in that adnexa, it's like, what is that? That's a gestational sac out there. That shouldn't be out there. What is out there? And there's something in it. That's an abnormal pregnancy. That's an ectopic pregnancy growing where it shouldn't be. Now, the treatment used to be, way back when, is whack that tube out. We'll just take the tube. And they realized that wasn't such a great idea. It took a lot of women's fertility with it. So then they did the basic salpingotomy. They go and they cut a hole in the tube, take out that pregnancy, and try to save the tube so it improves a woman's likelihood of being fertile in the future. Now we have medical therapy. So if an ectopic pregnancy meets certain criteria, a certain beta level, a certain size, etc., they can actually treat this now with methotrexate, which stops mitosis. So that embryo growing out where it should not be, they give methotrexate and it stops growing. Basically, it dies and then it gets resorbed by the body. The thing you know about methotrexate is two things. One, it's not 100% effective. The efficacy of methotrexate, the best data out there is at 97%, and that's a skewed study. It drops as low as 70% in some of the studies. The reason that's important for us is if someone comes in and they got methotrexate 2 days ago for a diagnosed ectopic, but they're hypotensive, tachycardic, and having severe pain on the side where we know their ectopic is, they ruptured. They're a failure of methotrexate. So know that that can still rupture even if they've gotten methotrexate. The other thing to know is when they get methotrexate, they often will have pain as that embryo dies. It just causes local pain. So it'd be a little bit confusing for us if someone comes in having received methotrexate and they're having abdominal discomfort in the area where the ectopic is. If they are hypotensive tachycardic, assume it's a rupture. If they're really symptomatic, you're going to call the OBGYN and say, here's the deal, they're here really symptomatic. What's the scoop? What do you want me to do? Just know that methotrexate it's wonderful for women because it helps preserve their fertility, but it makes our job a little more difficult in deciding, did it work? Did it not? Is it just a side effect, or have they ruptured with this ectopic? So medical therapy is another option for people who have ectopic pregnancies. Now, RhoGAM is something, there's been all kinds of blog debates about and podcast debates about RhoGAM right now, but for a test purpose, RhoGAM is something that is delivered to Rh negative mothers. So one of the other tests you get in anyone who's pregnant is not just their quantitative beta and not an ultrasound. You also need to know their type and screen, so you know their Rh status. Rh negative women with anything related to the pregnancy where baby's blood could get into mom's bloodstream gets RhoGAM. So basically, virtually anything that can happen to that pregnancy, threatened miscarriage, ectopic pregnancy, true miscarriage, trauma in pregnancy, and that includes even tiny trauma, bumping your belly against a countertop when you're this big pregnant, you get RhoGAM. And RhoGAM is basically 2 different doses. If it's 12 weeks and under, you give them 50. If it's over 12 weeks, you give them 300. And the goal here is if baby is Rh positive and Rh positive blood gets into Rh negative mom, it's not a problem for that baby. But it's a problem for the next one if mom develops antibodies to that sort of transfusion from baby to mom. So no, RhoGAM is indicated if Rh negative moms when something may have gotten baby's blood into her system, trauma or a pregnancy-related problem. Now, weird pregnancies can occur as well. So say you get someone who says, I'm so excited, this is my first pregnancy, it's so cool, I had my positive pregnancy test 3 weeks ago, and look, I'm already showing. Wow, that's early to show, right? 3 weeks, that's early to show. And gosh, when you send the beta, it's 100,000. What is up with that? Either her dates are totally off, or there's something wrong with that pregnancy. If she's also hypertensive, that is a molar pregnancy. So what's happened is the trophoblastic tissue, it's not a baby that's growing in there, it's trophoblastic tissue that's just going crazy. And they end up with really high betas, they're much more prone to get preeclampsia, and they are much bigger size than dates. What's in there is this trophoblastic tissue. So that combo of things is something where you worry. What they have in there is this. Your ultrasound is going to show what looks like a snowstorm. And when they go in and clean that stuff out, it looks like this. It's these little bubbles of trophoblastic tissue. Most of these are benign. It's just trophoblasts kind of gone crazy. They just clean it out and everything's normal. Rarely they're malignant. The key is for us to recognize that that's just not a normal pregnancy. Something's wrong here. And that's a molar pregnancy. And that's also ripe for questioning. They'll give you size greater than dates or beta way out of whack or hypertension, something that doesn't fit what should be a super early pregnancy. Now, pregnancies, as you get later in the pregnancy, several things can go wrong that are problematic for baby and or mom. Abruptio placentae we think of in trauma all the time. So I have a second or third trimester pregnant woman. She's got a belly out to here, and she's in a car crash, or she falls down a bunch of stairs. And if she comes in with a very painful uterus, usually tonic, it's like they're in labor, but it's tonic, it's very tender, I worry that the placenta has been pulled away from the inside of that uterine wall. We think about it in trauma, but I want you to also remember it can happen spontaneously. And there are two groups. It happens spontaneously and most often. One is maternal hypertensives. So a woman is, particularly if she is hypertensive when she goes into her pregnancy, or she develops it during her pregnancy, that can cause it spontaneously. The other is the drug-using group, particularly cocaine. So cocaine also increases the risk of a spontaneous abruption. And again, these women present with painful uterus. Depending on how much it's pulled away from the wall, they may or may not have any vaginal bleeding. If it's a contained abruption, so it's just pulled away sort of in the middle, but the rest of the placenta is still stuck inside the uterus, they'll have blood in there, but that's what's irritating the uterus and making it cramp down, but it won't get down anywhere out where we see blood. If you learned in school that you see dark red vaginal bleeding and abruption, you kind of learned a little bit wrong. If it gets out, there's enough that gets into the sort of bleeds underneath the placenta and gets out to where you can see it, yes, it's dark red. But usually it doesn't get out there. Your key is a tonic, painful uterus. Okay, that's blood underneath the placenta where it's pulled away, irritating the uterus. The problem with this is it's a very hard diagnosis to make. You would think ultrasound would be awesome for this. You'd think ultrasound would see this lovely pulled away part, but it isn't. Ultrasound is terrible. So our job is, if we're worried about abruption, to get that person to L&D, where they'll put them on a tachometer and they'll watch them. Or in a trauma patient where that belly has been bumped, we send them upstairs to get watched for several hours to see. Ultrasound's not good enough. Okay, ultrasound is not good enough for this one. This is what it is. So here's the uterus with the placenta in there, just lovely, but it's pulled away where that number 1 and the arrow is. It's pulled away there. And again, if that hasn't gotten out where it actually can leak down through the cervix, you may never see any blood from below. All you're going to have is this tonic uterus with maybe fetal distress, depending how much of this has been affected to the blood supply to the baby. Now that's abruption, placental abruption. Placenta previa is where the placenta settles itself, as it sort of settles in the uterus, across the exit sign. It settles itself across the cervix itself. It's not uncommon for this to be there early in pregnancy, but as your pregnancy gets bigger, it pulls up along the wall. If it's there in the second and third trimester, that baby can't get out. And you've got this placenta, which is unbelievably rich in blood supply. The blood supply to a placenta is the size of your thumb. It's remarkable. And if you now have that bleed through the cervix, bright red, painless, potentially lethal blood. So you have a lot of blood coming out there. Painless, third trimester, bright red vaginal bleeding is previa till proven otherwise. You put nothing in there. No finger, no speculum. You disturb that thing anymore, you can end up with a potential life threat to mom and baby. So previa, over the exit sign, bright red blood, usually painless, nothing goes in there. Abruption, maybe nothing from below, and painful. Their uterus is painful, totally different. So here basically is a normal placenta on the left, nice and planted up high, where you'd love to see it. On the right, the baby can't get out of there. There's a placenta right over that exit sign there. And this is what an ultrasound turns out to be very good for previa. So ultrasound, they can put the probe right over the symphysis pubis. They're right there looking at the cervix, and they can see the placenta right over that opening. So ultrasound, good for previa, bad for abruption, but quite good for previa. Now, when you got other things that can happen in pregnancy, and this may start early in pregnancy, is pregnancy-induced hypertension, eclampsia, and preeclampsia. So when it comes to pregnancy-induced hypertension, our OBGYN colleagues are very focused on this, as they should be. Our job in the emergency department is, you don't have to remember numbers, but if you have anyone who's pregnant, whose blood pressure is 140/90 or higher, and they don't have a pre-existing history of hypertension, that's higher than it should be. And if they know their blood pressure started out really low, I'm always 100/60, then there are some fudge factors in there that say, well, even if your blood pressure is normal but higher than your baseline, that's a problem. You will not need to know that for the exam. But if they give you a patient with a blood pressure of 140/90 and they're pregnant with no pre-existing hypertension, they're going to want you to know that's not normal. Okay, that is a concern in a pregnant patient. The reason it's a concern is that what can happen, especially as pregnancy goes along, is they can develop preeclampsia. Preeclampsia's definition now is 20 weeks or greater gestation, new onset hypertension 140/90 or greater, plus something that says the end organs don't like that. So either proteinuria, and that's greater than a 1+ dip in the ER, so you dip their urine, 1+ done, or any of the other 5 things on this slide. So thrombocytopenia, creatinine greater than 1.1, right? I mean, how many people have you seen with a creatinine 1.2? That would be considered an end organ problem in this particular situation. Transaminases more than twice normal, pulmonary edema, or visual symptoms. I'm having blurry vision. It's important to put this together because this is a risk for mom and baby. This is and know this definition. And what they might do for you on an exam is give you a 3rd trimester pregnant woman with an ankle sprain, but also complaining of a headache and some blurry vision, and has a blood pressure of 150/100, and has urine that's 1+ positive for protein. They're going to want you to know her problem isn't her ankle sprain. Her problem is her preeclampsia. So you're going to need to know some of this to know when to recognize it. And they're not going to try to fool you. They'll probably give you an elevated blood pressure because that's part of this is the diagnosis. Just be aware of that. And that's the definition now of preeclampsia. What is no longer in the definition is cankles. So, and any woman who's been pregnant knows that it's not uncommon at all for you to have cankles for the last trimester of your pregnancy. You've got these ginormous ankles. That used to be a definition. It is no longer. So that is off the list. So the list is, and that slide before, that's the definition. Now, there are women that are definitely at risk for this. For the first prima gravidas are at risk. Extremes of age are at risk. And again, the symptoms that we worry the most about are things like headache, visual changes, et cetera. Those are the things we worry the most about. The treatment for this is to call the OBGYN and say, guess what? I have somebody here I think is preeclampsia. The ultimate treatment is delivery. They can do some temporizing things along the way unless the patient seizes. The thing to know about that now takes it from pre-eclampsia to the real deal eclampsia. Eclampsia is preeclampsia plus a seizure. And what they'll come in with is altered mental status, visual changes, hyperreflexia, and they've seized. And the kicker to this is you can get the treatment is to deliver the baby, and the treatment is to use something like MAG. Okay, so you're going to treat, benzos are fine, but MAG is kind of what they want you to answer. Either work, but MAG kind of fixes the whole problem. Benzos fix the seizure. So magnesium, deliver the baby is the ultimate thing to do. The problem is you can still be eclamptic up to 8 weeks postpartum. And this is a wonderful thing for an item writer to grab on. And the way I would write the question if I were an item writer is I would have you called to the bedside of a seizing 32-year-old whose very worried husband is holding their newborn infant at the bedside. Right? You need to recognize that she is still just postpartum. She's not pregnant anymore, but that can still be eclampsia. And again, the treatment of choice is magnesium. You can use benzos for the seizure as well. That baby's got to get out if the baby's still in there. Now, a weird twist on this is what's called HELP syndrome. And HELP syndrome tells you what it is. Okay, the initials tell you what it is. It's hemolysis, elevated liver enzymes, low platelets. Okay, it's again, end organs having trouble in part of the eclamptic syndrome. And the kicker to you for this is you're going to see on your CBC schistocytes. I'll tell you, schistocytes are never good on a CBC. There's nothing I can think of where there's schistocytes on a CBC that are good. TTP causes schistocytes. HELP causes schistocytes. This is, again, a form of preeclampsia. This basically ends up having to go to the operating room to take that baby out. Okay, they bed rest them, but if they persist, they take that baby out. Now, appendicitis you heard about, the GI talk, is the most common surgical emergency of pregnancy, and it can be a little bit of a conundrum. That appendix can get moved around during pregnancy while baby takes up all of this real estate. So you may end up presenting with back pain or with symptoms that are a little different. Just know that they can be a little bit wily on this one. The most common misdiagnosis in this is pyelo. Again, because it's kind of pushed up and back, we may misdiagnose it as pyelo. And when it comes to UTIs in pregnancy, all UTIs in pregnancy need to be treated. Okay, even if they're asymptomatic, all UTIs in pregnancy need to be treated. The key because it increases the risk of miscarriage. And if it's true, honest to God, pyelo, it increases the risk of fetal wastage, even second and third trimester. So you need to treat UTIs in pregnancy. Now that brings up the idea of drugs in pregnancy. Which drugs in pregnancy are safe and which ones aren't? I'll tell you, they have all these different categories. And what I've done for you is kind of collect a couple of pages of this. The ones that are safe, most of the antibiotics are safe. The cyclines aren't a great idea because of the teeth that changes that it has in kids. The fluoroquinolones aren't a great idea because of bone changes in kids, but there's a long list. The penicillins are fine, the cephalosporins are fine. Antiemetics, there's a list you can use as well. Ondansetron is not on that list at this point, so it's off. So those are the ones you can, and a lot of vaccines, the inactivated vaccines are totally fine. Asthma, you treat exactly the same if you're pregnant or not. So that's absolutely fine. When it comes to hypertensives, we'll get into the no-nos. Most are fine, but remember, ACEs and ARBs are absolutely no in pregnancy. Don't use those. Anticoagulants, you can use heparin, cannot use Coumadin. Antivirals and miscellaneous are there. And actually what's simpler to remember, honestly, is the contraindicated list. And the things to know on here are ACEs and ARBs, warfarin, aminoglycosides, cyclines, fluoroquinolones. Okay, those are the things you can't use in pregnancy. Let's get down to labor. So now we're getting down to let's get that baby out of there, for heaven's sakes. So preterm labor is defined as labor at less than 37 weeks of gestation. That's just the definition of this. And for us, depending when you see them, you may see them at 32 weeks or 28 weeks when they're starting to have preterm labor. That is like a stay out of there, bubba kind of thing, and get them to an L&D, because that's a big risk if they actually rupture, especially that early. It's a risk to mom and to baby. Most of the time with preterm labor, we just put people at rest. Sometimes they need tocolytics in addition. Our job is just to recognize it. So if somebody you think might have preterm labor, get them somewhere where they can watch them on a monitor. Now, what we don't want to have happen is PROM. Okay, you don't want people to have premature rupture of membranes. That is a devastating problem for both mom and baby. And what they'll come in with is saying, gosh, it's kind of weird, but I think I just peed myself. I didn't feel like I had to pee, and I'm 32 weeks pregnant, but gosh, I think I just peed myself. Worried that they actually ruptured their membranes and they've actually lost the amniotic fluid. The worry of this is that they can actually go into early labor and they can get an infection up there. And the baby needs that fluid. So if the baby's lost or they get basically oligohydramnios, that's a problem for the baby. So our job is try not to put anything up there, but if there's vaginal fluid coming out, you can see if it's actually amniotic fluid by checking the pH. Okay, the pH of this should be alkalotic, should be less than, or greater than 6.5, and you can look for ferning. You can send some of that fluid to the lab, and they can put it on a slide, and when it dries, it's actually beautiful. It makes this ferning pattern. It's gorgeous, just beautiful, but that's amniotic fluid. Okay, nothing else down there makes that beautiful ferning. So, and again, we worry about preterm labor. If you think someone's ruptured their membranes prematurely, nothing goes inside, they go to L&D, and you can maybe send some of the fluid for pH and for ferning. One of the things you also do not want to see, I've only had one of these happen in my job, is basically a prolapsed cord. Somebody who is in labor, and when you go take a peek in there, or what you see when you actually look at the perineum, is you see cord. That is devastating. That's the cord between the baby's head and the mom's basically pelvic brim. What you need to do is put that mom knee chest, so she put her chest down, butt up in the air. You put your hand in there, and you push that baby up. You get that baby to the point where you can feel a pulse in that cord, because you want that pulse in that cord, and then you get them up to L&D or to a cesarean section where they can immediately get that baby out of there. Now, what will kill a mom, and you hear this, right? You hear it's code blue L&D. There is nothing that makes me more queasy than hearing code blue L&D. Some disaster has happened up in the labor and delivery suite. And not infrequently, if it's truly honest to God a code blue, it's an amniotic fluid embolism. This happens around the time of delivery, and it is honest to God an embolism. So it's something foreign in the blood. So like a clot would be in the blood. This just happens to be a big bunch of amniotic fluid. So they get the embolic symptoms, the tachycardia, the hypoxia, all of that. But they also get the problems of having this fluid that this baby's been floating around in for 9 months, full of all this tissue thromboplastin and all this junk in it, into mom's bloodstream. And they go into raging DIC. The mortality rate is more than 50%. It's often in the first hour. It is a devastating problem. So amniotic fluid embolism, C-section, precipitous deliveries, right around the time of delivery, devastating, absolutely devastating. Now, once you've had that baby, not all is not better, you can have a postpartum hemorrhage. This is usually the first 24 hours after delivery, and the way to fix this, it's usually just a uterus that says, I am exhausted. I have been in labor for 36 hours. I've had this baby in here for 9 months. Just give me a break. I just want to rest a second. You don't let that uterus rest. You take the ball of your hand and you basically rub on that uterine fundus until it starts to clamp down, and you treat that with things like Pitocin. So prolonged labor is the biggest risk for this. A woman who's been in labor for just days trying to get that baby out of there. So we may see this, if you have a delivery in your emergency department, you may end up with a woman who's like this. So know that that's a problem. And uterine rupture, fortunately, is rare. We used to see uterine rupture back in the day before they were really good at this sort of cesarean section, women who basically VBAC, basically the vaginal delivery after cesarean section. They can do those now pretty safely. So, but you can every once in a while see a uterine rupture. Devastating to mom and baby, okay? Devastating to mom and baby. You tend to lose them both. Now, a few other things that can cause trouble after somebody's had their baby. Retained products of conception, what they tend to do is continue to bleed. Those patients often just go to L&D. Our job is just to know that that's maybe a problem. Or if they have retained products and they come in a little while later, they may get infected retained products. So no, they can come in either infection a little while after delivery, usually several days, or they still have bleeding because there's just still stuff up there and I didn't completely get rid of the placenta, etc. Women can also lacerate their lower GI tract or their lower GU tract when they have delivery, particularly precipitous. And they can actually, the worst one I ever saw is a woman who basically tore open the bottom of her cervix, ripped it where it got up to the arterial supply to the uterus. The arterial supply to the uterus is like a fire hose. And I've never seen anybody bleed like that. We packed her entire vagina with basically 4x4s and put pressure on this thing and ran her out. She ended up with a crash C-section just to save her life. So that can be a problem as well. And then uterine inversion, which is kind of backwards, but what uterine inversion is usually from what's called placenta accreta. So the placenta kind of gloms inside the uterus and it gets kind of stuck. It's placenta accreta. So instead of pulling away and then eventually getting delivered, the placenta's kind of jammed in there, but usually the cord is still sticking out. The baby's gone. The baby's been delivered. It's all lovely. If you tug on that cord, what can happen is if that placenta is stuck inside, it will just pull the uterus right out through the vagina and evert the whole thing. It's called uterine inversion is what it's called. That it can be potentially devastating for mom. She can bleed, she can get infected, she can lose her uterus with that. So that's a big problem. They basically had the thing come out. That's a surgical emergency. Now you heard about trauma in pregnancy before, so this is just a sort of summary slide for that. One of the things to know about trauma in pregnancy is that they give you a scenario on the exam where the patient's on their back and hypotensive. Turn her on her left side. They're going to want you to basically take that baby off the woman's IVC. So just get her turned a little bit on her left side. You may take care of the hypotension with that. Then the last couple little bits, perimortem C-section. I don't think they'll ever do this on an exam, but it's something to know about because one of the things, if you do this right, first of all, it's devastating to ever get in that position where the mom is so usually trauma, so dramatically injured that she is going to die and the baby is viable. Basically, it's two dying people right there in front of you. If you do a perimortem C-section right, meaning the mom is either just dead, not dead too long because then the baby's dying too and then everybody's terrible. Basically, it is if you can get that timed right, where you get this drain on mom out, and so that you can resuscitate the baby separately. And now mom can just focus on herself as far as her own physiology is concerned. You actually increase the savior rate of both. So you actually improve mortality. It's not fabulous, but you improve the mortality of both rather than both of them dying. So perimortem C-section, the baby needs to be viable. Basically, you need to do it timed right around the time of maternal death or preferably right before maternal death, and you actually will salvage both more. It's not tons more, but you basically will get them more. And it's not pretty. It is a vertical incision. It is get that baby out of there as soon as possible. We'll fix everything else later. Last slide. Endometritis is an infection of the upper genital tract, usually from tissue still being there. So premature rupture membranes, we talked about it. Bugs can get up in there. Baby's still in there, but they can get infection inside the uterus. The retained products will do this. Prolonged labor. They come in sick. It's often foul smelling from below. They're septic looking. They look sick. It's broad spectrum antibiotics and getting them admitted. And then the last thing that happens to a lot of women who breastfeed is mastitis. It's basically usually that's pain, erythema, fever, and a quadrant of the breast usually that's infected with this. It's a staph infection, so it's very easy to fix with a cephalosporin. The key is not to have mom stop pumping or breastfeeding. So have her pump during that or go ahead and continue to breastfeed. Otherwise, she'll just get more engorged and it's more uncomfortable. So go ahead and have her continue to breastfeed or pump, give her a cephalosporin, usually takes care of itself very quickly, and they do very well. is what they look like. It's usually a quadrant, not the whole breast, so it's usually just part of it. And only in Vegas can you go to Hangover Heaven. This is a bus that drives up and down the Strip. It is air-conditioned with IV fluid hanging everywhere and on Dancitron delivered liberally. And you can basically recover from your hangover in nice air-conditioned, hydrated style. I wish I thought of that business. All right, we'll do the questions. Thank you very much.